Then Hello, everyone, and welcome to this month's Veteran Oral Health Action Collaborative call, Practice-Based Opportunities for Data Collection. My name is Stacy Chazen. I am Director of Education and Leadership with the American Institute of Dental Public Health, and it's my pleasure to be your host for today's call. We'll quickly go over some housekeeping items. Today's session is being recorded, as we do with all of our calls. The session also includes both a presentation from our esteemed presenter, Dr. Irene Hilton, who we'll introduce you to shortly, along with an interactive learning part. We ask everyone to please add their personal pronouns to their Zoom screen name if they're so comfortable. Please stay muted until you're ready to speak. And as we'll share with you a little later on in the call, continuing education credits are available for today's session. Next slide, please. For those of you who haven't been with us before, or maybe if you have, I want to give you just a brief introduction to our organization. CareQuest Institute for Oral Health, which supports this project, works through areas of activation and influence to bring forth ideas and solutions to create a more accessible, equitable, and integrated health system for everyone. And we thank them for their support of this effort. Next slide. Our organization, the American Institute of Dental Public Health, or AIDPH, as we are known, has a vision for an equity-oriented oral health workforce that is prepared to lead. Our mission is to foster professional excellence and advance innovation in the education and practice of dental public health. We encourage you to visit our website to learn more about us, including how we're focusing on 4 particular communities: rural residents, veterans, the LGBTQIA community, and people with disabilities. Next slide. So the Veteran Oral Health Action Collaborative, what is this all about? Next slide. VOHAC, as we call it, is a framework for learning in action that includes monthly seminars that are focused on health system transformation in the context of veteran oral health. For those of you who have been joining us, you know that each month we have a specific topic of focus within veteran oral health. Those evolve over the course of the year with learnings reinforcing one another and presenting a diversity of perspectives and learnings. As I mentioned, our call today, as all of our sessions, includes some interactive applied learning where we use case-based concepts to prompt you to create personalized action plans and serve as a think tank during an applied peer learning portion, which is going to follow our didactic presentation. As we've shared with you previously, you also have the opportunity to earn a certificate by participating in this program. For those of you who complete successful 6 competency quizzes based on our calls, you will be awarded a certificate in integrated care approaches to veteran oral health. You can do that by either watching these sessions live or by watching the recordings, which are posted on our website. If 2 or more individuals from an organization earn that certificate, the organization will be awarded a certificate of commitment to excellence in veteran oral health. And you will also receive and have the opportunity to complete a survey to earn continuing education credits if you attend this session live. Next slide, please. CareQuest's Medical Oral Expanded Care, or More Care program, which underlies this program, aims to address health disparities through the integration of oral health into primary care practice and the development of dependable oral healthcare networks. It focuses on both the integration of care and the coordination of care, and we encourage you to visit the CareQuest website to learn more. Next slide, please. Elements supporting integration within this framework, and which we focus on through the VOHAC program, include shared responsibility for the oral systemic connection, use of a referral network, transitioning care models, focusing on an environment of improvement, and the use of appropriate health information technology to drive positive outcomes. And our presenter today declares that she does not have any financial arrangement or affiliation with any corporate organization offering financial support or grant monies for this continuing dental education program. Next slide, please. So now we're getting to the more exciting part of today's call. It is my sincere pleasure to introduce Dr. Irene Hilton. Dr. Irene Hilton is a dental consultant for the National Network for Oral Health Access, and she works on developing health center dental program resources under NOAA's HRSA training and technical assistance funding. She is also a staff dentist at the San Francisco Department of Public Health. Dr. Hilton is board certified in dental public health and has dual faculty appointments at the University of California, San Francisco School of Medicine and School of Dentistry. Dr. Hilton, welcome. We're thrilled to have you, and I'm going to hand the microphone over to you.
Thank you, Stacy. I was going to say, next slide. Thank you. So the title of my presentation is going to be Community Partnerships for Data Collection. And some of those community partners will include your local federally funded health center and possibly any other dental private practices or organizations providing dental care that can outreach and help improve the oral health of veterans. Next slide. So here are the learning objectives. So we're going to be talking about data collection. Next slide. So I'm going to be talking a little bit about dental care and veteran care in HRSA federally funded health centers. And here you can see a map. There's almost 1,400 federally funded health centers located throughout the United States and Puerto Rico and territories. Next slide. And of those health centers that all have primary care as part of the services they provide, almost 80% of them have at least one site where they provide dental services. Now, every year, the health centers are required to report data to HRSA, which we call the Uniform Data Set, or the UDS. And 2 weeks ago, HRSA released the data from 2022. So this is the latest that we have. And here you can see that there was over 30 million people, unique, what we call users, but these would be patients or individuals that accessed health centers for some type of health care. It doesn't mean the 30 million were exclusively medical care. Some could have, the majority are, but some could have been coming in just for dental care or behavioral. It depends on the policies of the health center, whether or not you can access multiple services or you can just go to one of the particular services. And of those 30 million, almost 400,000, or about 1.3%, were identified or self-identified themselves as being veteran, which seems intuitively seems kind of low, considering that health centers are targeted or located in areas of high need where there's medical shortages of workforce personnel. And as you may have heard in previous sessions, or if you've read the CareQuest and Institute's publications on veteran health, you know, veterans are more likely to have poor oral health and have certain conditions, be low income, that will make them more likely to receive services in health services or dental services in health centers. Next slide. And here is actually a page from the Institute's and CareQuest's white paper that came out 2 years ago, and the link is here below, where they did an analysis of where the locations that are veterans are most likely to be served by zip code. And you can do this by matching, because when we talk about the UDS data, you can match the zip code of the health center with the number of veterans that the health center reported that they were serving. And this is what you would get. So it's not patient-specific data, it's data related to again, where the health center is located. Okay, next slide. So HRSA has a 300-page manual on how to complete the UDS and the reporting that we do every year. And this is the line a definition that is of interest to us today. One of them, which is line 20, we'll call line 25, which is the question, which, as you can see here, is that HRSA says must be asked, that you have to include this question to gather and collect this information in an intake, patient information intake at each health center for each patient, which is, they define, again, a veteran as a discharged individual who served in active, again, that talks about the areas, the different services, but also includes public health service and people that served in the National Guard and reserves. So next slide. One of the challenges then that we find or have found, as some studies have shown, that I'll link to later, is that one of the challenges is when you only ask, you put on your intake is, are you a veteran, versus stating that whole definition. There was a study that showed that if you use that entire definition, the long definition, the number of people that say yes go up like 3 times. But then you run into the issue of the time that it takes to go through that whole definition. So then you start getting, again, these challenges about time for data collection. How are you asking the question? Are you handing a pad, an iPad to the patient to self-identify, or is someone verbally asking the question? If you are using paper, and some health centers, are still using paper for intakes that gets transferred, how does that happen? There's room for error, standardizing workflow. These are all the challenges just to collecting this one piece of data that's really the basis for developing, planning, and really understanding the population that you have, let's say in the health center, or actually in any practice. So again, some of the solutions could be to these challenges: personal touch, having a person actually ask the question, having it be the full question, or follow up question that really gets into that whole definition, using utilizing peers, community peers to ask these questions, really cutting out the paper and going into the real-time electronic entry into your reporting documentation, and then standardizing work, which means training of staff that does these intakes. Next slide. So the UDS actually collects more than just this. So they do patient demographics, which again includes veterans as a special population, along with individuals experiencing homelessness, individuals with HIV, and other populations. It also collects from the electronic data collection that each health center has to report selected diagnoses, such as diabetes, hypertension, the select services that are rendered. And in the case of dental, it aggregates CDT codes. So it will tell you if a patient has had a preventive service, a diagnostic service, oral surgery services, for example. And then there's a whole set of quality outcome measures that are recorded for each individual in the UDS. Next slide. The limitation right now, I'm going to say currently, so like in last year's data, is that, and prior, is that at the state and national level, the data is not reported at the patient level. So it's an aggregate. So each health center, again, when let's say they report they saw 1,000 veterans, we don't know anything about those 1,000 veterans. We don't know race, we don't know sex, ethnicity, what services they utilized. Were they dental only? Were they medical and dental? Have they been diagnosed with diabetes? And we don't know any kind of outcomes. Now, the data is available at each health center level, but then the question in terms of analyzing is there's variability in each health center with their capacity of their health center IT team to be able to analyze and do these additional analysis that would have to be done in order to specifically pull out the veteran population and look at their demographics and their outcomes, because there's many other data demand collection and reporting demands on health center IT. So again, you get some health centers that have looked at this, and these are the early adopters and the high functioning health centers in terms of veteran specific programs. And then you have others that may not have the capacity. Next slide. Now, everything's going to change slowly. So HRSA right now is in the middle of what they're calling the UDS Plus, which is actually going to be the first year of reporting what we call UDS Plus, which is their HRSA's modernization of the UDS, is going to be the 2023 year. Now, the reporting is not due. So let's say data is being collected this year. It's not going to be due till February of 2024. So the earliest the data is going to be available is August of 2024. And again, it's going to be voluntary, for reporting for this year's data for health centers. There is, at least I don't know if maybe somebody else on this call may know of what the timeline is for them to transition to mandatory reporting, where all health centers are going to have to report mandatory, because we're not going to be able to look at state level and national data until every health center is reporting. But at least for the ones that will be, they're going to be reporting this UDS Plus, which is de-identified patient level data. So it's the same elements that are currently being reported. So again, race, sex, ethnicity, the conditions, the services that are being provided, and the quality outcomes, same thing, but it's going to be no new elements, but they're going to be reported at the patient level. So with increased data granularity. This is going to completely change everything, because it's going to allow us to cross-reference all of these variables and be able to do better planning. So, and this is what I thought was really interesting. If you go to the HRSA UDS website and you look at their FAQ about UDS Plus modernization, and this in green text is actually taken from the website. This is the example they use. It includes veterans and talks about how UDS data cannot show the number of patients that are veterans and are experiencing homelessness, because again, it's two different questions which are not tied together to individual patient. But with UDS Plus, you will be able to tie together how many veterans that were seen at the health center level were also homeless. So you can imagine, next slide, how exciting this is going to be in terms of being able to really understand who comes to the health center, what are the conditions and the way they access. So again, just using veterans as an example, we will be able to look at the almost 400,000 veterans, let's say, that accessed last year, and see how many of them actually accessed dental care. How many were dual users of medical and dental, and so how many were only in medical. We will be able to look at the demographics to assess issues of equity. So for example, of the veterans that did go to dental, are there disparities by race, ethnicity, in terms of who is able, or sex, who did go to dental versus who didn't go to dental. We'll be able to see, again, just as a whole, which veterans were diagnosed with chronic conditions. How many have diabetes? How many have hypertension, homeless, and allow us to develop much better programs. And we'll also be able to look at outcomes like for veterans, how did accessing dental care, was there an association between their, whether they were in control or out of control diabetes and other types of outcomes. So this is really, again, going to be next level in terms of improving oral health for all the patients that health centers serve, but certainly for veterans as a specific population. Next slide. And again, why health centers? Because health centers, and as you saw from the 30 million of all the programs that the federal government funds, whether it's the VA, the active military, public health service, Indian Health Service, the health centers is the largest system with almost, again, 30 million users. I think it's 23 or 4 million medical users. And again, that makes it one of the largest healthcare systems in the nation. And because of the nature of health centers, with co-location of multiple services in what, if not in the same system, sometimes in the same site, medical, dental, behavioral, there's such an opportunity. And as more and more health centers go to integrated electronic records, so that every discipline can see the same record, to see everything that's going on. And again, with integrated management at the administrative level, that allows planning, again, of program, the potential for health centers to really develop. And some, again, there's such a spectrum when you have almost 1,400 organizations. We already have many early adopters that have developed or worked in that process of developing a system of whole patient care, patient-centered care that, along with enabling services, again, allows, as you can see here, the patient and family to, again, receive wraparound services that addresses social determinants of health. And if you apply all this, the potential for veterans to receive optimal care, including oral health care in health centers, should improve, as time goes on. Next slide. So now I got to take a brief moment to just talk about like NNOHA and where our perspective is coming from. So again, we were founded over 30 years ago by a bunch of health center dental directors who needed to get together to peer network. We receive funding from HRSA, and we have for the last 10 years as their training and technical assistance partner for all things oral health. Next slide. That was our founder. That reminds me, John McFarland in the 70s before infection control, if you saw, no glasses or anything. Again, as part of our training and technical assistance, these are the services that we provide to health centers. Again, the goal of improving the oral health care the patients health centers serve. The one I want to focus on for here is the learning collaboratives. Next slide. So we have developed this sort of like vision for a delivery system designed for oral health equity, which includes many different components, and is founded on the idea that the traditional dental office is not the only place that you can receive dental care, or should not be, or cannot be the only place that you receive oral health care, that there's other multiple methodologies that have already been developed, and there's probably going to be more in the future, but that health centers do, again, because of the nature of health centers, already do all of some, maybe not one that does all of these things, but we have some that are doing some of these things. And in relation to veteran oral health care and chronic disease management, this part down here at the lower left, where we're looking at, although again, mobile dentistry and teledentistry could also be bought in to develop programming that brings in primary care, whether it's the physicians that are assessing, let's say, veteran oral health and referring to dental, or embedded dental staff in primary care providing services, or it's dental staff doing screenings and then referring to medical. That there's a lot of existing models already on the integration that we have seen and worked with health centers to develop. Next slide. So I just wanted to briefly, again, give you some examples. And again, if you can visualize how at the health center level this could be utilized for veterans, we have done, we've worked with health centers to develop these integrating oral health and primary care practice, which again is the primary care staff doing the assessments and appropriate referral, looking at specific populations. Some of, again, probably already were involved, veterans were in already some of these cohorts that have been involved in these learning collaboratives. We have done integration of behavioral and oral health, where it's the dental staff that are administering the PHQ-2 or PHQ-9 and referring patients with elevated scores for behavioral health referral. And currently, right now, we're in our fourth cohort of the integration of diabetes and oral health, which again is looking at patients who's with out of control diabetes and A1C over 9 in health centers, and has the medical staff again assessing and referring for dental care, and the dental staff looking up A1Cs and arranging follow-up for patients that are due for their A1Cs, as well as preventing treatment. Next slide. So this is what's happening in health centers. But again, we have the advantage because we have co-located, we have electronic systems potentially integrated. Can we translate any of this to non-health center settings? Yes, we can. Next slide. So I did want to put down these resources that have been developed by NAC, which is the overall organization for health centers. And the one on the right is the recent, earlier this year, release joint between the Dental Public Health Institute and NNOHA on these best practices of providing oral health care to veterans, that if you're looking or you have implemented a program or you're planning a program to improve veteran oral health, you may want to take a look at, just to help you in the planning process. Next slide. So just some of the things to think about, again, if you're a dental practice or you're looking to implement a program, again, and you want to collect data, looking at what data you want to collect, and starting with just the one thing about, are you a veteran? Moving on to like the protective health information, which is about chronic disease conditions, or patient-generated data on satisfaction. How are you planning to collect data, paper versus electronic? Where are you going to store the information? And how will you use this data? Is it going to inform your treatment approach and your referral options? Next slide. And just a brief moment on each one of these things. The veteran status, again, as we've learned, it's usually a question. Asking it verbally, using the whole definition becomes important. What are you going to do with that information? Is that going to lead to more questions about social determinants of health? If someone does say they're a veteran, then does that, trigger your trauma-informed care considerations or behavioral health screening? Or again, are you going to have resources available? Next slide. Again, you have a medical history. You want to ensure that, again, that who the individual's regular source of care is. And then they're going to, the individual will identify, veteran will identify what their chronic disease conditions are. And then that can, again, trigger certain treatment planning considerations. Next slide. Never forget patient-generated data. Again, there's patient satisfaction with the dimensions of care and changes in the patient's perceived oral health status, and there are some validated tools to use. Next slide. So in conclusion, the health centers, we are in a unique opportunity position to improve veteran oral health, but we're limited right now by our data collection capabilities. But again, in the very near future, we're going to have this tremendous potential to unlock the data that we already have and be able to develop better programs. But there's already things that can be done by programs that are not based in health centers to already start thinking about data collection to help improve your veteran oral health programs. Next slide. Okay, so here's my contact information. Now I'll turn it back over to Stacy.
Thank you so much, Dr. Hilton. That was wonderful. And we're starting to get some questions in. As folks, we do have a big group of people on today, so we're going to ask folks to pop their questions into the chat. Lawrence Hill asked, is there information available regarding the total number of health centers, not just grantees, and how many of the total number of centers offer oral health services? How many of those provide preventive services only, and how many provide preventive and restorative services?
Yes, so like the HRSA's NTAPs, we can access, if you're looking at the national level, yes. So if you go to the HRSA website, you Google UDS HRSA, you go to 2022, it will give you the aggregated national data for the entire, and by state data. So not health center specific, but national and state, for all of the elements in the UDS. And there is an element later in the UDS. So you can tell if a health center has dental because you'll be able to see they have dental staff, like dentists, therapists, things like that. But then later on, when it goes to services, it divides, like I said, the services into the CPT coding categories. So it'll tell you, that all the health centers, for example, they did 200,000 oral surgery services, things like that. So you'll be able to tell if they're doing preventive, if you do preventive CDT codes versus the restorative ones. So you can get that data nationally and by state.
Thank you. Other questions for Dr. Hilton?
Now, actually, I did mean to say, so I did say how many health centers offer dental services, because the definition that we use is that they have to have at least 0.5 dental FTE dental provider and or 500 encounters. because some health centers contract for dental services, so you don't see dental providers um, under the FTE staffing section of the UDS, but you do see it under the encounters. So if you assume if they have over 500, they must be contracting and somebody's providing those services somewhere.
Okay, thank you. And Dr. Sue Keller asked, what dental or medical electronic record is used by health centers and can it be standardized?
Oh, if only it could. If not the and actually we wouldn't even need for it to be standardized, but what we need is ONC, because that's been the biggest barrier. And I think we've had other presentations, and we've all come to the same conclusion, which is that IT is one of the barriers, right, to full to integration, right, to creating a whole person care. So you can have like 1,000 different systems, but they all have to be interoperable. That's the key. They don't talk to each other. um, it even at the health center level, like I said, they can have a medical, like for example, they could have eClinical Works, and they could have the EagleSoft. eClinical Works for medical, EagleSoft for dental. The two aren't talking to each other. And even we are now finally getting to the level where health centers are on consciously selecting a completely integrated system like Epic, which has a wisdom module, or eClinical Works, which has its own module, which then allows providers on both sides, for example, to be able to go in and see the complete record, on the other side. So, but health centers, again, because each health center is a nonprofit organization, they decide for themselves which health center, what EHR they're going to use. Although we are seeing, again, trends away from the separate, over the last 20 years, from having two separate, an EDR and an EMR that don't talk to each other, to these integrated EHR systems.
Great, thank you. So I'm going to transition us now to the interactive portion of today's call. And if there are follow-up questions, I know that Dr. Hilton has made herself available and provided her contact information, which we will include in our follow-up materials as well. So thanks again, Dr. Hilton. So our applied interactive learning, next slide, please. As you know, if you've been here before, we're going to break out into some rooms shortly where we're all going to consider in a peer-to-peer discussion a scenario that we're going to share with you using the model on the screen. Next slide. Everyone is going to be assigned to a breakout room. You'll have a facilitator from AIDPH or CareQuest in your room with you. And when you come back from your room, we're going to do a report out. If there's someone in your room who's willing to be that reporter when we return, that would be wonderful. So we ask you to seek volunteers when you first come together, and we'll be sharing back knowledge after all of these sessions are done to share the strategies and takeaways with all of you who've joined us. Next slide. So here is the scenario we asked you to consider today. There's a dental practice that specializes in geriatric care for U.S. military veterans. The practice is keen on tracking oral health outcomes for aging veterans, but faces difficulties in establishing a standardized data collection process due to the complexities of data collection and sharing of health information. Next slide. So we have 4 questions here. We know that you're not going to have enough time to dive into all of these with any kind of depth. So when you go into your breakout rooms, we're going to ask you to pick perhaps 2 of them that you'd like to focus on and have a discussion. The rooms will be recorded so that we'll be able to capture the takeaways afterward. Next slide. Okay, I'm going to ask my colleague Rahel to stop sharing the screens, and we're going to go into our breakout rooms momentarily. When you see the invitation pop up on your screen, please accept it. And we'll be coming back at 12:45 Eastern. And if you don't see an invitation pop up, that means that you're staying in this main room with me. Okay, welcome. And if you're in a place where you can turn your camera on, as Dr. Steve Geierman has modeled for us. We appreciate that. We'd love to see your faces. Can always count on you, Steve, for that. Great. So many other people. Wonderful to see all your faces wherever you are, including in your car, Celeste Terry. Thank you. It's great. Okay, so I am going to read the scenario one more time quickly to you. There's a dental practice that specializes in geriatric care for U.S. military veterans. The practice is keen on tracking oral health outcomes for aging veterans, but faces difficulties in establishing a standardized data collection process due to the complexities of data collection and sharing of health information. So, first, let me ask, is there someone who's willing to share just some high-level takeaways from our discussion when others return to this main room with us? I wish I could offer you a gift card or something. I just can't. I don't have anything to offer except my appreciation.
I volunteer Steve.
Oh, I don't know. Is that kosher?
It is kosher, and I know where you live, Sandy.
Okay. All right. So we're going to move on then. We're going to move into it. So Steve, since you're going to do that, I'm going to give you the privilege of picking the first question that we're going to tackle. Which of the four, and Grace posted them in the chat, which would you like to take on first? Did we lose Steve?
Oh no, I'm here, but I will defer to Sandy. I'm too busy taking notes.
Okay, Sandy, pick a question.
I'm reading through them, and let's go with, let's just start at 1.
Okay. How can the dental practice design a practice-based data collection process that captures relevant oral health outcomes while accounting for the complexities of data collection? What are some thoughts?
I would offer something, Stacy, in terms of, though they are by no means any further ahead than FQ8Cs are, but it would be really helpful if the data collection that the VA does could be modeled and integrated with what FQ8Cs do. Okay, does that make sense?
Reactions to that? What do folks think?
That's great, Steve, suggestion on that, because it will make it so much easier when you roll it up and receive it as well, to the VA, and continue that same thing instead of having broken languages out for the veteran himself.
I agree, and we're seeing it more in projects that we're doing in Missouri, that instead of everybody trying to create their own when they're trying to work together, it's better to model one off of the other and go from there, instead of having two completely different systems and then trying to get them to connect.
Yeah, if I might say, I think Steve's hand motion even said more than his verbal when he went like this. The VA sees such a tremendous number of our veterans, but their dental program is extremely limited to the number of veterans that can receive dental services there. So I would think this isn't specifically to the specific question, but I think the issue of how many veterans are actually able to get services, are able to get dental services, and looking at the two systems, there's, I think, very fertile ground for a partnership between the VA and the primary care centers.
I would offer just one clarification. Where Larry used the word dental, I would not.
Yeah.
because that's a rabbit hole we all live in already,
Agree.
where the FQHC medical and dental doesn't talk to one another. If we consistently use the word oral health as part of overall health and force them to bring it forward. And I would just reiterate a comment I posted for Irene, and it was too late to be asked. But my question is, when you don't have electronic records that speak to one another, and there is patient harm done, and you can point that out towards the lack of communication, that is a liability issue. And I hate to do shame and blame and use the stick, but that's often what we have to do. So I would just bring that up as something in your back pocket when your administrators say, we can't possibly do that, it's too expensive. You can't possibly not do it if patient harm and liability comes into play.
And Steve, this is Lori. I don't know. I cannot get my camera on. My apologies. It just changes my background. I don't know. Anyway, one of the things I would want to see too, as we work towards having this oral health data collection, is some kind of repository where that information is collected and it's shareable. So people that are researching, writing grants, whatever the case may be, would have that all in one place.
I captured that.
Thank you.
Okay, another one of the questions.
Oh, could I comment on the last question?
Absolutely.
I just want to make a comment that we work in FQACs with multiple federal programs already, and oftentimes there are separate systems that we have to report data to. So I somewhat like the idea of having a repository, because I mean, if you know specifically what you're trying to share with other entity, it would be easier, I think, to just deposit it there. And that would also be on the list of things on the oral health side to be aware of in terms of trying to do some type of integration where the dental side is not specifically focused just on oral health. So those are my comments on that. And I'm not sure about the next section, because I have to read the question. So I'll pass it to someone else, but thank you for letting me make that comment.
Stacey, before we go to another question, I would just like to point out, we could land a human being on the moon more than 50 years ago, but we can't make medical and dental records talk to one another. And that boils down to money. And I was in Michigan, and there were 10 community health centers at this program, and they were all ditching their electronic dental record because it didn't serve them. But they were all going to buy the ones that the other ones were throwing away. And I knew that because they talked to me. So I stopped my presentation and I said, excuse me, this is the case. What are the 10 must-haves that you would put in an RFP for an electronic health record? And once you do that, don't buy any, because the vendors have got us over a barrel. They can do this, but it's only with united strength that we can actually move them forward. So we need to think about this. And if we had one big system, and it could be multiple vendors, but they have the same RFP things, that repository Lori asked about, they're all they all have similar values. They could be gathered. So I would just, and I know that sounds like you're nuts, Steve. I may be, but this is real. And how long are we going to put up with this?
Yeah. If I might comment for 1 second. First of all, I want to confirm that Steve is nuts, but
Thank you.
no, I actually, I can remember a number of years ago when I was looking for a system, and all of the dental vendors said that they could be integrated with medical, and all the medical vendors for data systems said they could be integrated with dental. And I won't go into vendor names or anything, but I was very frustrated in trying to figure all this out. And so I was at a primary care meeting in my state, and I pulled one of the major dental information vendors together with the medical vendor that we were using. And I said, okay, so you both said you work with each other. So what's the deal? And they were both standing there, and they both admitted that it was a lie, that they don't. And so if it's just to piggyback on what Steve was saying, it's not only strength in numbers, but I think what we need to do is both to push HRSA for that as a requirement. They don't have to require what company it is. They just have to require that your system does that. So I think it has to come from the HRSA end. And I think we also have to push it from the NAC end, because basically the only people that have been pushing for it, to my knowledge over the years, are the dental people. And we don't get listened to a whole lot. So we've got to think about trying to get the folks who might listen to start thinking about coming together. And it might even be worth having a meeting with HRSA and NAC and whatever, to bring the folks together at a table and say, this is what needs to finally happen here. We have to stop talking about integration and really do it.
I'm sorry, Lawrence, what is NAC? I have a lot of.
So NAC is the National Association of Community Health Centers.
Okay,
so
thank
it's
you.
a large umbrella organization that all the FQHCs belong to.
They know who medical and mental health is. They often punt oral health to NOAH.
Right.
And that's the shame too. Stacy, I'm curious, before we move off this question, for this last conversation, who has an opposing viewpoint? Who doesn't believe what we were just talking about? Or why it can't be done? Because I think that's an important piece to bring to the table.
So Steve, before anyone answers, I just want to acknowledge that everyone from the other breakout rooms has returned. So if I'm going to suggest this, since you were voluntold to be the reporter, and thank you for accepting that graciously from our group, I wonder if you could give a brief recap of that, and then you can pose that question to the full group.
Okay, are we starting now?
Go.
Yes.
Yes.
All right. So we looked at question number 1, and we basically came to this conclusion that data collection at FQHCs around oral health would be most efficient and effective, especially for veterans, if it somehow mirrored the data collection that was done at the VA. So that was an important piece. We also talked about not focusing on dental. That was the beginning of our problem, and it will continue to be unless we start talking about oral health as part of overall health. There was a question about the need for a repository so that this data collected at various FQHCs within a state, within the country, could be shared among one another so that we could have more oomph when we're trying to make our case. But we're often stymied by the fact that though we could put a human being on the moon 50 years ago, medical and dental electronic records cannot talk to one another. So one solution was, be clear. What are the 10 things that an electronic health record should offer? And then hold the vendor's feet to the fire. So that, and don't buy until they do. And then we may get more traction if we could convince HRSA and or NAC to move forward a requirement in that area. And I had also posed a question to Irene that we didn't get to. And Irene, it was the question where, though we all live with medical and dental not talking to one another, if a patient is harmed, and it can be shown that the lack of this communication between the health records was a significant factor, that's a liability. I hate to use a stick rather than a carrot, but it seems to me that we need to be able to point those instances out to make our case as we move forward. Stacy, that was the end of our voluntoldness.
Thank you, Steve. Any reactions to what Steve shared?
Well, Stacy, this is Lori. One of the things, you'll laugh, but my visual in my head of this topic is hot potato, because I feel like everybody's thinking this is a great idea, but then they pass it off to somebody else and they go, yeah, this is a great idea, and they pass it off to somebody else. So I think that there needs to be a specific group, or somebody that takes the lead on this to start making it happen, rather than everybody going, yep, it's a great idea, who's going to do it? So I think it needs somebody to take it and move it forward.
Yes, Dr. Sue Keller.
You're on
Oh,
mute.
you're on mute.
I think one of the solutions actually could be to build a better system, make it cheaper, and then provide it for free to the early adapters, and basically get everybody onto a system that's better than the system that they have. You're not going to ever change the companies. And you're not going to necessarily change people's wanting to use the product that they're comfortable and familiar with, but sometimes money talks, and something that's more effective and the support for it is provided. Really, really good support could make a difference in making people want to choose a system that's easier and ultimately work better. So rather than trying to fix the systems that are already out there, make a new system that's better.
Can we get someone to report out from the room that Christina was facilitating? Did anyone volunteer or was voluntold?
Do you need me to do it, Matt? I was taking notes.
Please,
Okay.
Christina.
No problem. So in our group, we kind of bounced around with the questions a little bit, but we acknowledged that the first step would have to be, obtaining an approved practice management software. And we talked about what other people were using in their practices. And someone mentioned automations, like clinical decision support tools would be helpful, because it would flag something from one provider for another, to make note of something that may interact, like infection level was also brought up. For dialysis, transplant, cancer patients, the coordination between them and their different providers and needing to reduce infection level in the mouth. And that's all I had in my notes.
I was the helper for Grace's group, and I can report out. So we had a lot of discussion about approaching these populations, the geriatric population, as a holistic view. We want to not just only look at the oral health indicators such as periodontal disease, like loss of function, mobility, but we also want to look at their environment and community. Look at are they mobile? Do they have a support network? Can they even access oral health care where they're at? What kind of support they need? And so all of those go into consideration when it comes to what kind of data do we want to extract from these demographics. And there was talk about how there's still value in doing face-to-face interviewing with these patients rather than just doing it remotely. Sometimes you can tell some data, maybe not like very hard number, but when you talk to somebody, you can start to pull out more data just through motivational interviewing. And so that was what we talked about for question 1. And there was also discussion that we were already talking about earlier here about the EDRs, EHRs, reporting capabilities, and possible solutions to how we can bridge those gaps. And Dr. Sue Keller already spoke to that point. She was in our group. She was a really great contributor. So that's about what I had.
Thank you. Does anyone else want to add anything? Okay, then I'm going to ask Rahel to please share the slides again and take us to the next slide. So our next steps here, we want to remind you, ask you to register for our next VOHAC session, which is going to take place on September 28th, which will be on the topic of the role of data in advancing integrated value-based care in oral health. We invite you to complete the session evaluation to earn 1 CEU for today's session. And I want to note that you need to have participated for at least 20 minutes on this call, to have been on the line for at least 20 minutes to be eligible for CEUs. I say that we had a number of people join close to the end of the call. Perhaps you were in and out, but that is a requirement of the CEU offering. And you also have an opportunity to complete a competency quiz to work toward the program certificate or certificates that we talked about earlier on. So I would once again like to thank CareQuest Institute for Oral Health for their support and partnership in this project, and to Dr. Irene Hilton for being a wonderful presenter and resource for us today. I want to thank Dr. Steve Geierman for being a good sport when voluntold to be the reporter, and to all of you for taking part, sharing your expertise, sharing your curiosity, and joining us today. We hope to see you on the next call, and I wish you a happy rest of your Thursday. Thanks, everybody.